Okay, hello everyone. We are starting our presentation, and I believe it must be our fourth, might be fifth. I forgot
Yes,
the number.
yes, you are audible.
Thank you, Anna. Okay, we are starting our today's lecture, and I forgot the number, the count. I think it's our fourth lecture. And thank you, Anam, for having me. And it's like initiative of KOSHA Health, and this is her brainchild that we should help our fellow pharmacists, not only to help them to prepare for foreign exams, but also for those pharmacists who are not working and want to contribute and want to join again uh, the clinical pharmacy services or the hospital pharmacy services. So, whatever we are discussing in these lectures are something which we have learned in our clinical pharmacy experience. I have more than 10 years of clinical pharmacy and hospital pharmacy experience. So, and I am working as a chief pharmacist in OSHA Institute of Chest Diseases. So, this topic is quite relevant to my domain, and we will discuss, particularly in these lectures, we are discussing guidelines. Uh, these things I believe will help you if you work as a pharmacist in any hospital or in any even the clinical setup because these asthma entities are very common. So I think we should not delay any further and we should start our presentation. So uh, first of all, I would like to tell you about the objective. The objectives of this lecture is I will define asthma and I will define COPD. I will tell you how to diagnose, and particularly in this lecture, I will focus on the guidelines. For asthma, I have compiled GINA guidelines, and you can get the guidelines on just Google on going to the Google, and I'll share the guidelines as well. I will share the link of the guidelines. Asthma, it is GINA guidelines, and for COPD, I will discuss GOLD guidelines. So let me start. Starting with asthma. So the guidelines describe asthma as chronic inflammatory airway disease, and it's really important why these guidelines say that asthma is chronic inflammatory disease. And you will see when we will be discussing how to treat asthma, you will see we will focus more on anti-inflammatory drugs, anti-inflammatory inhaling agents more, and you will see that the guidelines are just for inflammation, to combat inflammation, and you will see why. And basically, these guidelines define asthma as it's a chronic inflammatory disease, and it is characterized by variable airflow obstruction. What is mean by variable airflow obstruction? Uh, Basically, these asthma patients have paroxysmal attacks, mean they have sudden attacks of shortness of breath, dyspnea, basically, and then they have hypersensitivity of their bronchi, and they have obstruction, they have airway inflammation. These patients have. So, but sometimes they do not have this asthmatic attack. They maybe have normal airflow. So that is why the definition and the guidance define asthma as, sorry, chronic inflammatory airway disease with variable airflow obstruction. And you will see why guidelines define asthma as chronic inflammatory disease and with variable airflow obstruction. We will see. So now, this is very important to understand when a patient has the asthmatic attack. You can see this in picture. On the left side, you can see a normal airway. Its lumen is wide open. It has thin mucosal lining. And but what happen if a patient have an asthmatic attack? His or her lumen get narrow. There is swelling of mucosa. Then there is mucosal edematous, and the mucous secretion got thick, and there is a spasm, and we will see why. I have discussed the pathophysiology in later slides, so you will see. So yeah, before we go to the pathophysiology, we characterize asthma as intrinsic asthma and extrinsic asthma based on their trigger factors, based on their pathophysiology. GINA guidelines characterize asthma as intrinsic and extrinsic. We'll discuss more about extrinsic asthma and what is extrinsic asthma. Basically, extrinsic asthma is mediated by IgE. It's a kind of a type 1 hypersensitivity. We will discuss in detail about this, how it gets mediated by IgE, what is type 1 hypersensitivity, and extrinsic for this slide in particular, you need to remember that extrinsic asthma is mediated by IgE antibodies, and it is a type 1 hypersensitivity, and generally it has trigger factors like pollen, dust, mites. And if you ask the patient about their family history, they usually give a history of allergic reactions like rashes, eczema, and it has a good prognosis if you control or manage these triggering factors like pollen, dust, mites, then they have a good prognosis. But there are some asthma which are intrinsic in nature. They are non-allergic. They are due to some viral infection. Even they can be triggered with just cold air. There are some drugs like NSAIDs and some even smoking can make these patients to have an asthmatic attack. So there are some intrinsic asthmatic patients as well who are not who do not whose pathophysiology is not mediated by IgE, so we treat them in a different way. Then this is something I have already discussed. That if you tell me about if you discuss about extrinsic asthma, it is kind of allergic in nature. In nature, it is a type 1 hypersensitivity, and I have told you we will discuss this in detail. And the patients, if you take history, they will report some kind of a family history of allergic reactions like eczema, rhinitis, etc. So now the pathophysiology of extrinsic asthma. Uh, yeah, I know it is difficult and it's very heavy slide, but let me make it easy for you. It's really easy. It's the type 1 hypersensitivity. What happens is if any patient who get in contact with any virus or any allergen, his airway or the epithelial cells of air comes in contact with any allergen, any virus. So epithelial cells releases some alarmins, you can say ALA alarmins, some cytokines. And here TSLP is really important. I will tell you when we will discuss about the treatment, I will tell you why this TSLP is important. But for now, you just need to remember this: whenever you inhale a virus which try to damage your airway epithelial cells, or you inhale any allergen like pollen, dust, etc. So your epithelial cell will release some alarmins such as TSLP, interleukin 33, and interleukin 25. And what they do, they basically activate the antigen presenting cell, and particularly the name is dendritic cells. And why I have tell them they are antigen presenting cells? Because they present these antigen whatever this does virus to T helper 2 cells. And what these T helper 2 cells do, they basically differentiate. And uh, for this slide, you just need to remember this. I'm repeating because this is a very difficult thing. Whenever you inhale a virus or any allergen, uh, the airway has some epithelial cells. They release some alarmin, some chemicals, some cytokines, and here TSLP is really important. And what this TSLP do is it activates antigen presenting cells, basically dendritic cells, and that antigen presenting cells travel to the lymph node where T helper cells present, and these T helper cells start differentiating, they start proliferating. Now, the next step. What the T helper cells do? when they get activated, they also release some interleukins. They basically release interleukin 4, interleukin 5, and interleukin 13. And here you need to memorize that interleukin 4 and interleukin 13 is really important because there are some drugs which act on these interleukins, and I will discuss them later. So, what these interleukins do, they basically activate beta cells and they start beta cells to produce some IgE antibodies. And then these IgE antibodies get adhere, get stuck or stick to the surface of the mast cell. So these two steps are really important to understand. I'm repeating these two steps again. So what happens is whenever the first time in your life is pain, you encountered any virus, you encountered any allergen, you do not get any asthmatic attack. You just what your body do is that virus or that allergen goes to the epithelial cells of your airway. It releases the alarmist, which is TSL, the interleukin 25. They activate that dendritic cells, which is antigen presenting cells, and that antigen presenting cells activate T helper 2 cells, and the T helper 2 cells also releases some interleukins, some cytokines, basically interleukin 4, 5, and 13. And then they tell beta cells to produce IgE antibodies, and then these IgE antibodies get stick or adhere to the marker. So what happens is these two steps are called sensitization. Now your body is sensitized to that antigen. Now what happens if the same allergen or same virus attacks your body again? So what happens is basically this slide will better explain it. So you can see in the middle there is a mast cell and it has antibodies, the Y-shaped antibodies, and you can see the inhaled allergen get attached to that antibody. So now what happens? This mast cell will, and then it produces histamine, leukotriene, and the histamine, leukotriene will cause bronchoconstriction. Another thing this mast cell will do, it will stimulate T helper 2 cells again, and that T helper 2 cells will produce interleukin 5, and this is very important. Interleukin 5, I'll tell you when we will discuss about treatment. So this interleukin 5 basically increase the production of eosinophil and it increase eosinophil mediated inflammation. It damages tissue and it is responsible for chronic inflammation. Another thing this helper 2 cell will do is it also stimulates the production of cytokines from beta cells, and it will again produce the IgE antibodies, and it also activate the antigen presenting cell, the dendritic cells, and again it will increase the production, the cross linking of IgE antibodies with the allergen. So this is what happens on the molecular level when you have an asthmatic attack, when a patient has having an asthmatic attack. So I'm repeating this thing. It is really important to understand how drugs work. So I'm repeating this thing so you get to understand. So the first two steps are responsible for making you sensitive to the allergen or the virus. But this cascade, which you are seeing on your screen, is basically responsible for you to have an asthmatic attack. So what happened when the allergen which already have sensitized you, you will have the mast cells which have antibodies. That allergen will bind to the antibody of that mast cell, and then that mast cell will degranulate. It will release some histamine, leukotriene, which cause bronchoconstriction, and then we have T helper 2 cells which get stimulated and they will produce some interleukin 5 and which cause increased production of eosinophil, and it will also cause eosinophilic mediated inflammation which damage our tissue, which causes chronic inflammation. Uh, it will do three things. No? It will release interleukin 5 to have eosinophilic mediated inflammation. It will stimulate beta cells and it will also activate antigen presenting cells, the dendritic cells. So now, uh, another type of asthma I already discussed with you guys, which is intrinsic asthma, and it is not non-allergic. It is because of due to some viral infection. It can maybe of due to cold air, even gastroesophageal reflux disease. Because when this acid reflux happens, it also can cause some kind of bronchoconstriction in asthma. So they are not the same. Their pathophysiology is not quite the same like an extrinsic asthma. Therefore, we categorize them as an intrinsic asthma. And then there are some drugs which can produce asthmatic symptoms like beta blockers, like NSAIDs, and even secondhand or passive cigarette smoking can have asthmatic symptoms to children, especially to children. So, moving forward, how asthma presents. Generally, patients having asthma have dry cough, and it's very important to memorize that patients who have asthma have dry cough, and it gets worse at night. They have shortness of breath, it's called dyspnea. They have chest tightness, and why they have chest tightness, I'll explain. And they have wheezing sound, they have a whistling sound when you auscultate, and especially when you breathe out, when you expel, and you auscultate, and the doctor basically auscultate, they hear a wheezing sound, a whistling sound basically. So this is how it is. This is the same thing I have written. Okay, and I have told you in the previous slide that when you auscultate and the patient is exhaling, you will listen a whistling sound from the patient. So this is how you can diagnose an asthmatic patient. Another thing which help doctors to diagnose asthma is when you do a percussion, you will feel that the lung is expanded, and I will tell you why the lung is hyperinflated in this asthmatic condition. But what it do is when the lungs get hyperinflated and you percussion it, you tap the body, you will listen a hyperresonating sound. And I'll tell you why the lungs get hyperinflated when I will talk about the pathophysiology. So uh, this is a test which is really essential for asthma and COPD, and it's called spirometry. We have a device. As I have told you, I work in Ojan Institute of Chazis, which is a Chazis hospital. So we have a spirometry device available, and this device us a volume of air which is expelled. It tells us the volume of air expelled in first second, and it also tells us the total amount or the total volume of air expelled by the patient in one breath. So what is FE1? FE1 is the amount or the volume of air expelled in 1 second is called FEV1. Okay, I'm repeating this thing that the volume of air expelled in first second is FEV1, and the total volume expelled in one breath is called FVC, forced vital capacity. So what we do is we divide FEV1 with FEVC. So if a patient has, if is selling, let's suppose, 75% of his air or 80% of his air in his first second, then we will say that he is not having an asthma. But if he is expelling less than 80% or less than 75% of total air volume in his first second, then we will. Okay, there is a noise coming in. I should mute. Okay. Okay, so basically, I'm repeating this thing, spirometry tells us two things. The amount of volume expelled in first second is called FEV1, and the total volume expelled in one breath is called FBC, forced vital capacity. So if a patient is expelling, exhaling basically, exhale uh, 80% of volume, let's say, or 90% of air volume in his first second, then we will say, oh, okay, he has a normal pulmonary function. But if he is exhaling less than 75% or less than 80%, then we will say, oh, he does not have normal pulmonary function test. He does not have normal spirometry test. He might have asthma. It's not a confirmatory test, but we will suspect, okay, he may have asthma. So uh, sometimes patient, if he or she has a mild asthma or moderate asthma, so patient have and you ask the patient to have a spirometry test. Normally they have uh, normal pulmonary function, so this spirometry test does not help. So we ask the patient if we suspect that okay, he may have mild or moderate asthma. We ask him or her to have some exercise or some cold air. So basically, we try to challenge him so we can diagnose the asthma. This is what we do, and we do not have this methylcholine. This was in guidelines, but we do not have this in Pakistan. And I have read that it is not recommended right now. Uh, so we do not do all these things. Although we ask patient to have some exercise. So if he or she have mild or moderate asthma, so we can check. We can diagnose asthma. So how you can differentiate asthma and COPD? Also, I will discuss COPD in detail in after some slides. But here I would like to tell you about the difference between asthma and COPD. How you can differentiate? How can you diagnose? How can you differentiately diagnose between asthma and COPD? So what we do is, first of all, if we have to do irometry test, we ask patient not to have a short-acting beta-2 agonist or the long-acting beta-2 agonist. And what are these? I will tell you a bit. So we ask them to stop their inhalers and stop their uh, uh, dry powder inhaler, and then we ask them to come the next day. So they have a dry period of like 24 hours or 12 hours, uh, and then we do a spirometry test, and we ask them to inhale and exhale on that spirometry machine, and we check FEV1, and we will check FE, and we check FEC, post vital capacity, and then again, then we administer short-acting beta-2 agonist, which is salbutamol. We have salbutamol available, and then we ask the patient again to have inhale and exhale on that spirometry machine. So if his symptoms improved, and we do some calculation and we see, okay, if his FEV1, the forced expiratory volume in the first second has improved, and it has improved more than 12% or 60. Let me tell you with an example that if a patient has forced expiratory volume before the administration of short-acting beta-2 agonist, is like he was exhaling, let's say, 1.6 liter oxygen. But after getting that SABA inhalation, short-acting beta-2 agonist inhalation, his FEV1 volume is like 2.1. So if you minus that and divide it with 1.6, 1.8, then you will see that there are 16% or 17% improvement in his FEV1. Then we will say, oh, okay, he has asthma, not COPD. So this spirometry test helps us to differentiate between asthma and COPD. So if a patient, the condition is improving after taking a short-acting beta-2 agonist, then we will say, okay, he is asthma. But it is not improving because COPD is a kind of disease, because it is a persistent disease, not like asthma that is episodic or paroxysmal. It's a persistent disease, COPD is basically. So it is not get really improved. Like there's no uh, you can say no. It's though there's some improvement, but there's no like huge improvement in the FEV1 if you administer short-acting beta-2 agonist. So this helps us to differentiate between asthma and COPD. So this is very important for the treatment. What we do is we basically differentiate patients that if he has mild asthma or moderate asthma or severe asthma. This classification is a little old, but still we use it, and it's really helpful. So if you have to treat the patient, first you have to think that if he is a mild asthma, if he has a moderate asthma or the severe asthma, and it's very easy to distinguish. If a patient has 2 episodes a week of asthmatic attack, uh, we will say he has mild asthma. But if he is getting on a daily basis, he's getting an asthmatic attack, then we will categorize him or her as a moderate asthma. But uh, if he is getting more and more asthmatic attacks throughout the day, he is getting asthmatic attack even in nights. As I told you, asthmatic symptoms may occur in night. They are frequently occur in night. So then we will categorize patient as a severe asthma. And this classification is really important for the treatment. And before going to the treatment, I will tell you about the pharmacology, something about the pharmacology, and then we will go to the treatment chart, how to treat asthma according to the GINA guidelines. And I will use these words SABA, LABA. And now, what is SABA? SABA is short-acting beta-2 agonist, and what is this? Basically, the smooth muscles of our lungs or of our airway have these beta-2 receptors. And what these beta-2 receptors do is they are decoupled beta-2 receptors. Basically, it is important to memorize for exams. So they basically relaxes the smooth muscles. So if you give any short-acting beta-2 agonist or any long-acting beta-2 agonist, like short-acting beta-2 agonist is salbutamol, it comes with a brand name of Ventolin or Salvo. Or if you, for example, you give long-acting 2 beta agonists like Formoterol, so they basically relaxes the smooth muscles. And Formoterol, there are two basically long-acting beta-2 agonists which are present in Pakistan, Formoterol and Salmeterol. Formoterol is highly recommended because it has rapid onset of action. It one to three long. See in a while that why it is important. And I have already told you that asthma is an inflammatory disease. So anti-inflammatory agents like corticosteroids are very essential. And how they produce their anti-inflammatory action. Basically, there are some inflammatory cytokines like NSKB. They basically inflame. They are some, and there are other cytokines as well which cause inflammation. And there's a long pathway I haven't discussed here. But just you to remember that these inhaled corticosteroids like budesonide and fluticasone, they basically inhibit pro-inflammatory transcription factor like NFKB, and which work as an anti-inflammatory agent. Then we have some long-acting muscarinic agents, LAMA, and you need to memorize this as well that smooth muscles have and acetylcholine receptors as well, basically M3 acetylcholine receptors. And what they do is they basically constrict the smooth muscles. So we give drugs which inhibit the activity of these receptors. So we give long-acting muscarinic receptor antagonist. Okay, and then if you recall the pathophysiology, I have told you some leukotrienes and some histamines also released when the mast cells degranulate. So we can also use some leukotriene receptor antagonists in severe diseases. And these methylxanthines, they are also smooth muscle relaxant, but we do not use, and it is not readily available in Pakistan as well. We do not use these tubulins right now because it's a narrow therapeutic index drugs, and its vasodilation is not significant. Then we have then these GINA guidelines also basically include some biologics, and they are very costly. We are not using here. I know I don't know if some hospitals are using, but GINA guidelines also included some biologics like omalizumab, mepolizumab, dupilumab, and tezepelumab. GINA guidelines has recommended the use of these biologics. How these work, I'll tell you. Okay, then we can also use some oral corticosteroids as well, uh, but they are not recommended unless you have a severe asthmatic attack. Okay, now what's the difference between GINA 2026 guidelines and the previous guidelines? Basically, in previous guidelines, if a patient have mild asthma, they recommend the use of short-acting beta-2 agonists like salbutamol, like albuterol. However, now GINA guidelines does not do not recommend the use of SABA alone in any case, especially in asthma. Why? There's a big reason, and they describe the rationale of this as well, because they say if you give SABA, and you give salbutamol or albuterol alone, what it will do, it will basically not treat the underlying condition, the inflammatory condition which patient have. It will only relieve the symptoms. So, though since the underlying condition has not been treated, patient will need more and more doses of these short-acting beta-2 agonists. And what will happen? Basically, what these short-acting beta-2 agonists do, basically if you will give an excess quantity of this beta-2 agonist, what they will do, they basically bind with these beta receptors, and what these beta receptors will do, they basically increase the level of CAMP, and they will increase glycolysis, and they will increase the production of lactic acid, and they will basically increase the acidosis, and the patient will present with metabolic acidosis in ER, or even these patients land in ICU as well. So when and it is very uh, difficult to basically distinguish between a patient having a lactic acidosis kind of dyspnea and then asthmatic attack. Let me describe this again. So what happen is if you give an excess quantity of beta to agonist, it will basically increase lactic acid, and it will cause metabolic acidosis or lactic acidosis, you can say. And this metabolic acidosis also results in tachypnea. Shallow breathing will happen, and uh, physicians uh, may confuse that shallow breathing or that tachypnea uh, with an asthmatic attack. So what our physicians do, they basically auscultate the patient's chest, and if they suspect that his breathing is improving but his condition is worsening, they ask their nurse to done an ABG test to check for lactic acidosis, and if they see that the pH of the blood has fallen and the saturation is also less than 92%, they put a pulse oximeter in their finger, and they check the oxygen saturation, and they have the results of ABGs as well. So if they see, okay, if this patient has metabolic acidosis, so they ask for ICU referral, and then they administer bicarbonate. So this is really important. This is the reason why uh, these GINA guidelines has now asked uh, not to use these SABA agents alone, especially. So back to our topic, as I told. So I was telling you about the treatment. So the GINA guidelines basically recommend that we can have two tracks. And before I discuss the GINA guidelines, how to treat, I must tell you, you need to remember that you have to categorize your patient. Uh, if he is having a mild asthma, he is having a moderate asthma, or he is having a severe asthma. If the patient has mild asthma, for example, he is just asthmatic attack 2 days or a week or fewer attacks, then you will say he has a mild asthma. But if he is getting asthmatic attack on a daily basis, then you will categorize him as as a candidate of a moderate asthma. Similarly, if he is getting frequent asthmatic attacks in days, then you will say he is having a severe asthma. So what GINA guidelines tells us, so if a patient has mild asthmatic attack, prescribe him with a low dose ICS formicol combination. You can see, and I have told you in previous slides as well, that even if a patient has mild asthma, now these guidelines ask us to initiate inhaled corticosteroids as well. Because now these guidelines treat asthma as an chronic inflammatory disease, and they think, and there are many researches which shown that if a patient has a short-acting beta-2 agonist, even in the mild state, they will ultimately have more hospitalization, they have more episodes of exacerbation, and they have more morbidity or mortality. That is why GINA guidelines has recommended to use the combination of low dose ICS and formicol. Why formicol is recommended, not the salmeterol, even if it is LABA? Because formicol has rapid onset of action and it has longer duration of action. Then, if a patient have moderate asthma, and I've told you what is moderate asthma, if a patient, for example, has daily episodes of asthmatic attack, then these guidelines ask us to prescribe the same low doses of ICS formicol, but ask him to take it on a daily basis. Similarly, if a patient has severe asthma, for example, and he is getting fewer, he is getting basically he is getting frequent attacks of frequent asthmatic attacks. So these guidelines basically ask us to have to add LAMA, the long-acting muscarinic antagonist, and biologics. I will discuss these biologics in a while. So now, this is the alternative pathway. It is recommended for those countries which do not have availability of the combination of formoterol with inhaled corticosteroids. So for all these countries, they recommend a SABA, but you have to use ICS with product like salbutamol. Because I have told you, alone SABA is not recommended now. It was recommended in previous guidelines, but it is not recommended now. So now back to the part one. So what happens if a patient has severe asthma? Now you need to add LAMA, which is long-acting muscarinic antagonist, which is tiotropium. It is really recommended in researches that you have to add long-acting muscarinic agent, which is used tiotropium. There are more evidences for its efficacy, but you have to add biologics as well. And these biologics are not present in Pakistan, and they are very costly. And since we treat patients for free of cost, it's very difficult for us to buy these drugs because we have budget constraints. So, but if you have to use these biologics, the guideline says you have to phenotype the patient. And what is meant by phenotype or endotype basically? You need to judge, you need to clinically examine the patient, that what kind of the inflammatory pathway the patient has, and what point of inflammation he or she is in. So what these guidelines suggest to have ask the patient to have an eosinophil count, ask the patient to have an FE charismatic count, and also have a serum IgE test. So, for example, if a patient has more eosinophils and their count is more than 300 cells per microliter, then you have to prescribe mepolizumab or benralizumab. And if a patient has a more count of ferric nitrate, which is 50 parts per billion, and he has more than that, then you can prescribe him with mepolizumab or benralizumab. Similarly, if he has elevated levels of serum IgE, then you have to prescribe omalizumab. So, as told you, these are monoclonal antibodies, and now the GINA guidelines has recommended to use these biologics. Now, this is the format is really important. We ask our patient. Basically, we treat patients completely free of cost. So they visit on a weekly basis to our clinic, and whenever they come to us, each and every time we ask the patient to explain how they are using their inhaler. Uh, just please confirm, am I audible now? And
Yes, you are.
yes, I am audible. Okay, thank you. So basically, we are in a free of we treat patients free of cost. So we basically ask our patient to explain how you are using your inhaler, because research says 60 or 70% of the time patients are not taking the inhalation correctly. There are two types of inhaler I have shown in previous slides as well. One is inhaler, another is dry powder inhaler. I've shown the diagrams in previous slides. Poster was inhaler, and the capsule, the combo have shown you they are dry powder inhaler devices, which the patient has to take with the dry powder inhaler device. So you have to memorize this. You have to explain the patient that we have to remove the cap, and we have to take the inhaler rigorously, and then we ask the patient to exhale completely, and then we ask the patient to place the inhaler in his mouth and tightly seal the mouth seal, uh, basically airtight that so the air do not leak, and then we ask him to press the button and be slow and deeply inhale all of the drug which contained in that inhaler, and then hold your breath for 10 seconds. We ask them to count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We ask them to count to 10, and then we ask them to exhale to his nostrils. Then this is what our OPD pharmacists do on with application. We have a captive pharmacist for that, because researchers say it is really important. Uh, so then there are some there is a chance of oral candidiasis if a patient is having this inhaler device. Uh, One more thing, we also recommend we also judge patients if they are not using their inhaler correctly. We ask them to use a spacer device. Uh, because it's very easy to take inhalation through spacer rather than without it. So we also recommend that spacer device to the patient. Okay, and we also ask the patient to rinse their mouth after having that inhaler, because there are significant number of researchers which have documented that the patients who are taking these drugs have more chances of candidiasis from the infection. And it's very difficult to treat about patient once has this disease. Okay, now then uh, we also recommend some non-pharmacological management of these asthmatic patients and COPD patients. We also have a pulmonary hypertension center now, and there are a significant number of researchers which say if a patient having asthma or COPD and they have pulmonary rehabilitation, there are more chances that they will need lesser amount of these pharmacological agents. Uh, One more thing, these asthmatic and COPD patients, I'll discuss COPD patients in a while. Uh, there is the guidance also suggests to have oxygen therapy. but there is a significant change in the recommendation now. Now, these guidelines ask us to check the saturation. If the saturation of the patient, oxygen saturation basically, we have a pulse oximeter, we check the oxygen saturation. If the oxygen saturation is less than 92%, so what we do, what these guidelines ask us, ये हमें कहती है कि आप जो है ना पेशेंट को फिर ऑक्सीजन थेरेपी पे रखें. अच्छा, तो ये पहले ये था कि जो है ना पहले जो ऑक्सीजन की बहुत फ्रिक्वेंटली ऑक्सीजन जो है थेरेपी इस्तेमाल होती थी पेशेंट के ऊपर, बट now guidelines recommend to check for saturation, and if the saturation is less than 92%, then you have to use the oxygen therapy. And the goal should be in between 92 to 96%. Either if it is adult or a child, the goal should be in between 92 to 96%. Now, we also ask our patient कि वो अपने पास ये peak expiratory flow meter रखें, a little costly, but ये बड़ा ज़रूरी होता है इन पेशेंट्स के लिए ताकि वो जो है ना देख सकें कि उनका जो एस्थमा है वो सिवियरिटी की तरफ जा रहा है या वो जो है ट्रीटमेंट की तरफ जा रहा है. तो ये डिवाइस होती है, इसको जीरो पे सेट करना पड़ता है, उसमें पेशेंट जो है इनहेल और एक्सहेल करता है और इससे पता चलता है कि वो कितना ज़्यादा वॉल्यूम को जो है ना एक्सपायर कर पा रहे हैं. अगर उसका जो लेवल है वो हर बार कम होता जा रहा है तो उसका मतलब एस्थमा जो है और ज़्यादा सिवियरिटी की तरफ जा रहा है. We also ask the patient to follow up after even अगर आपने पेशेंट को लेकिन वो सपोज माइल्ड एस्थमा है, हमने सपोज उसको स्टार्ट भी करवा दिया, सपोज लो डोज आईसीएस, हमने उसको कह भी दिया कि भाई अगर जब अटैक आए तो ले लेना. इवन देन हम उसे कहते हैं कि आपको 2 वीक बाद और 4 वीक बाद जरूर फॉलो अप करना है. एंड देन वी चेक अगेन, वी चेक वी डू स्पायरोमेट्री अगेन, ताकि पेशेंट की सिवियरिटी की तरफ न जाए. और अगर 3 महीने तक हम देखे होते हैं फॉलो अप में कि पेशेंट जो है ना कोई इतना ज़्यादा सिवियरिटी की तरफ नहीं जा रहे, उसके कंट्रोल हैं, तो वी कैन स्टेप डाउन एज वेल. बट अगर जो है ना पेशेंट की सिवियरिटी की तरफ जाए तो रिप्रेडिक्ट जाता है. तो फॉर पीडियाट्रिक एविडेंस भी अब इसमें ऐड हो गया है. तो ये केयर स्टडी है, ये भी यही है कि अब जो है आपको फॉर्मेटॉल आईसीएस का कॉम्बिनेशन इस्तेमाल करना है, सादा इस्तेमाल नहीं करना. Now moving to the last part of my lecture is COPD. COPD भी एक heterogeneous lung condition है. इसमें पेशेंट को इन्फ्लेम ब्रोंकियल्स होते हैं, ब्रोंकाइटिस और एस्मा होता है, एल्वुलाई जो है ना एयर सेक्स के अंदर एयर सेल्स होती है, इन्फ्लेमेशन हो रही होती है और ये परसिस्टेंट होती है, एस्थमा की तरह नहीं होती कि एपिसोडिक हो, ये परसिस्टेंट डिजीज होती है और परसिस्टेंट एयर फ्लो ऑब्स्ट्रक्शन होता है. यही वजह है कि एस्थमा और सीओपीडी के अंदर अगर आपको डिफरेंशिएट करना है तो हम पेशेंट को कहते हैं कि आप आ जाएं, आप जो है ना अपना जो अगर आप शॉर्ट एक्टिंग डिकटोजैनिस ले रहे हैं या लॉन्ग एक्टिंग डिकटोजैनिस ले रहे हैं तो वो आप रोक दें. अगले दिन आ जाइएगा जब उसके पास 12 घंटे या 6 घंटे का वक्फा हो एक दवाई के दरमियान. तो फिर हम उसको पहले करते हैं कि स्पायरोमेट्री और फिर दोबारा चेक, फिर उसको साबा का इनहेलर कफ करवाते हैं और फिर दोबारा उसका चेक करते हैं. अगर हम देखते हैं कि वो साबा से उसकी रन जो है उसका वॉल्यूम इंक्रीज हो रहा है, उसका एस्थमा सबसाइड हो रहा है, तो स्क्रीन कुछ ऐसा है, अदरवाइज. So, there's a huge difference between the pathophysiology. It was an inflammatory disease, but here it is not in. If it was a hypersensitivity type 1 reaction, the pathophysiology has seen वो mast cells होते हैं, and then there is an allergic reaction. यहाँ ऐसा नहीं होता, बल्कि यहाँ पर inflammatory mast cells जो है macrophages होते हैं और ये जो मैक्रोफेजेस होते हैं जो अल्वुलाई एपिथेलियल सेल्स में होते हैं, ये मुख्तलिफ कीमोकाइंस जो है रिलीज करते हैं जो मोनोसाइट्स को अट्रैक्ट करते हैं, न्यूट्रोफिल्स को लिपोसाइट्स को अट्रैक्ट कर रहे होते हैं और फिर ये न्यूट्रोफिल्स जो होते हैं ये स्टिमुलेट करते हैं हाइपरसिक्रीशन ऑफ न्यूक्लियस और जिस वजह से क्रॉनिक ब्रोंकाइटिस होता है. सिमिलरली एम्फाइसेमा की वजह ये बनती है कि अल्वुलाई के अंदर जो हमारे पास जो न्यूट्रोफिल्स और मोनोसाइट्स होते हैं वो डिस्ट्रक्शन कॉज कर रहे होते हैं और साथ साथ फाइब्रोसिस बनना, फाइब्रोब्लास्ट बेसिकली मौजूद है तो फाइब्रोसिस शुरू हो जाती है जिसकी वजह से जो है ना पेशेंट की एक प्रॉब्लम रहती है. So now, what guidelines say? So these global initiatives of COPD guidelines का नाम है गोल्ड गाइडलाइन का global initiative of chronic obstructive pulmonary disease. So what these guidelines says is वो COPD को ऐसा कहती है कि ये जो है सिंड्रोम है और ये जो है ना कभी भी अलोन प्रेजेंट नहीं होता, ये हमेशा प्रेजेंट करता है, बल्कि मल्टी मॉर्बिडिटीज का लफ्ज यूज करती हैं गाइडलाइंस अगर आप पढ़ें ना। तो हमेशा जो सीओपीडी होगा ये प्रेजेंट करेगा विद कार्डियोवास्कुलर डिजीज या डायबिटीज या ऑस्टियोपोरोसिस या एंजाइटी के साथ। तो बल्कि इवन डिप्रेशन के साथ ये प्रेजेंट कर रहा होता है। तो डायग्नोसिस मैंने अभी आपको बताया कि हम इसी तरह कंफर्म करते हैं, हम स्पायरोमीट्री कराते हैं, और अगर ब्रोंकोडायलेटर देने के बाद भी, जैसे मैंने आपको कहा, स्पायरोमीट्री करते हैं, फिर ब्रोंकोडायलेटर देते हैं, फिर स्पायरोमीट्री करते हैं। अगर ऐसी V1 और ऐसी V2 का रेशियो 0.7 यानी 70% से कम आ रहा है तो देन इसे पेशेंट को सीओपीडी है। अगर एस्थमा में आपको याद हो तो मैंने कहा था 85% बताया था और 90% बताया था, यहाँ पर 75% बताया था। अच्छा, नाउ वहाँ पर जिस तरह हम डिवाइड कर रहे थे माइल्ड मॉडरेट सीवियर में, गोल्ड गाइडलाइंस जो आपके 2026 के आई हैं उन्होंने भी इसी तरह समझने करा है। पहले ही क्या करती थी गोल्ड गाइडलाइंस, ये डिवाइड करती थी सीओपीडी पेशेंट को 5 ग्रुप में, ए बी सी डी और ई। बट अब ये इनको क्लासिफाई करती है सिर्फ 3 में, ए बी और ई में। ठीक है। अच्छा, ये ए बी ई कैसे देखते हैं? ये हमारे पास एक कैट स्कोर होता है। बेसिकली हम पेशेंट को ये मैं आपको दिखाऊंगा कैट स्कोर और एमएमआरसी ग्रेड। ये मेरी लास्ट स्लाइड पे मौजूद है, और ये स्लाइड मैंने जो है ना चैट के अंदर जो है ऐड भी करती हैं। तो बेसिकली कैट स्कोर क्या होता है? ये 8 क्वेश्चन हैं बेसिकली, और इससे ठीक है स्कोर बनता है। इनविटेशन खुद भी फिल कर सकता है। हमारे यहाँ तो हमारे पास जो काउंसलर होते हैं वो इसको फिल कर रहे होते हैं। तो अगर उसका जो स्कोर होता है वो 10 से कम है तो हम उसे माइल्ड कह रहे होते हैं। तो हमारे पास 3 ग्रुप बन जाते हैं, ग्रुप ए, एक ग्रुप बी और ग्रुप सी। पहले 5 है, अब तो 3 ग्रुप हैं। यू कैन से माइल्ड, मॉडरेट और सीवियर, आप इसे कह सकते हैं। ग्रुप ए में वो पेशेंट्स होते हैं कि उनको लास्ट टाइम में कोई एक्सरसाइजेशन नहीं हुई, कोई सीओपीडी का अटैक नहीं आया, और जो है उनका कैट स्कोर जो है वो लेस देन 10 आ रहा है, और उनका जो एमएमआरसी का ग्रेड है वो भी 0 या 1 है। ग्रेड बी वो है जिनको मॉडरेट है, उनका जो है ना लास्ट ईयर से अब सीवियर उनको ब्रेथलेसनेस है, डिस्निया है, और उनका कैट स्कोर 10 है या 10 से ज़्यादा है, और एमएमआरसी का स्कोर जो है 2 या 2 से ज़्यादा है। इसी तरह ग्रुप ई में वो हैं जिनको ज़्यादा सीवियर सिम्टम्स हैं और उनको कोई भी मतलब सिम्टम्स हैं और लास्ट ईयर से ज़्यादा ये सीवियर डिजीज है। अच्छा, इनकी फिर डिजीज में भी इसी तरह ट्रीटमेंट ये था कि अगर माइल्ड डिजीज है तो सिंगल ब्रोंकोडायलेटर अगर आप देंगे तो इनफ। अब आप यहाँ देख सकते हैं, यहाँ पर आपने इनहेल कॉर्टिको चॉइस नहीं देना। अच्छा, अगर मॉडरेट है तो आपने जो है क्या करना है कि आपने लॉन्ग एक्टिंग बीटा तो जैनिस भी देना है और लॉन्ग एक्टिंग मस्कानिक एजेंट भी देना है, यानी कि टाइरोक्सिन भी देना है, और आपने जो है ना फॉर्मिटॉल वगैरह भी देना है। इसी तरह लेकिन अगर ग्रुप ई है तो, और ग्रुप ई ऐसा पता चलता है कि अगर उसका इग्नोफिल काउंट जो है 300 से भी ज़्यादा आ रहा है तो फिर आपने जो है ना उसको इनहेल करके चॉइस सिंपल भी रखता है। अच्छा भाई, ये कि आप इसमें क्या होता है, ईटिंग क्लासिफिकेशन में दो चीज़ों की बुनियाद पर है। आपने सिम्टम्स देखने हैं। सिम्टम्स आपने कैसे देखने हैं? एमएमआरसी स्कोर और सीएटी स्कोर, कैटेगरी, ये मैं अभी आपको दिखा दूंगा ये कोर्स क्या है। और दूसरा आपने उससे पूछना है कि लास्ट ईयर से उसकी सीवियरिटी कितनी ज़्यादा है या कितनी कम है। और फिर वही है कि ग्रुप ई के ऊपर ज़्यादा हमारा फोकस होगा, क्योंकि ज़्यादातर पेशेंट जो आते हैं वो 50 ईयर से ज़्यादा होते हैं, वो मल्टी कोमॉर्बिड्स होते हैं। तो ज़्यादातर पेशेंट जो लैंड करते हैं हमारे पास वो ग्रुप ई स्टेज में ही लैंड करते हैं, और ज़्यादातर हमें ये लाबा लामा साथ ही देना पड़ता है। अच्छा, ये मैंने आपको बता दिया कि अगर सीवियर होगा तो पहले आप लाबा लामा देंगे, यानी कि आप फॉर्मिट्रॉल और पैरासिटामोल साथ ही उसको इनहेल करवाएंगे। और अगर नहीं सकता तो फिर आप इनहेल कॉर्टिकोस्टेरॉइड कर देंगे। लेकिन ये जो पेशेंट्स होते हैं, क्योंकि ये मल्टी कोमॉर्बिड होते हैं, इनमें पेशेंट रेस्पिरेटरी इन्फेक्शन भी होते हैं, तो समटाइम्स जो है एंटाबायोटिक्स भी देनी पड़ रही होती हैं। और देन हमारे पास भी मोनोक्लोनल एंटीबॉडीज प्रेजेंट नहीं है, लेकिन जो है गोल्ड गाइडलाइंस के अंदर उनको एड ऑन थेरेपी के तरीके से लिए जो है ना रिकमेंड किया गया है, बिकॉज इस तरह के जो पेशेंट्स होते हैं वो मल्टी कोमॉर्बिड होते हैं, एज आई सेड मल्टी मॉर्बिड। अच्छा, तो देन वी हैव अ लॉट ऑफ चॉइस, वी हैव अ चार्ट, नॉट चॉइसेस। आपको पहले लाबा लामा ऐड करना है, देन आपको इनहेल कॉर्टिकोस्टेरॉइड ऐड करने हैं, लेकिन अगर उससे भी नहीं हुआ है तो फिर आप ये Tocilizumab act कर सकते हैं. We do not have these monoclonal antibodies there. लेकिन फॉस्फोडाइस्टेट और इनहिबिटर हमारे मौजूद होते हैं. इसके अलावा म्यूकोलेटर साइसे विजिट NH15 ये मौजूद होता है. ये पेशेंट को का जो न्यूक्लियस होता है वो जो थिक हुआ होता है तो म्यूकोलाइटिक एजेंट के तौर पर वर्क कर रहा होता है. तो दिस इज नाउ. अगर पेशेंट को एक्यूट एक्सेसरबेशन हुई है तो जो है ना आप उसको वही ब्रोंकोडायलेटर यहाँ पर आप काबा दे सकते हैं. गाइडलाइन से आप यहाँ पर काबा दे सकते हैं, वहीं पर सल्बुटामॉल दे सकते हैं. और अगर पेशेंट को बहुत ज़्यादा एक्सेसरबेशन है तो आप ओरल कॉर्टिकोस्टेरॉइड भी दे सकते हैं 5 days के लिए. ऐसे पेशेंट से हम एक्सक्यूटम चेक करते हैं. बैक्टीरियल एक्सक्यूटम आ रहा होता है, फाउल स्मेल आ रही होती है तो हम देख लेते हैं ये बैक्टीरियल इन्फेक्शन हो सकता है. तो हमारे लैब वाले डॉक्यूमेंट कर देते हैं तो एंटीबायोटिक किया जा सकता है. एज आई सेड थेओफाइलिन वगैरह पाकिस्तान में भी अवेलेबल नहीं है बिकॉज इनके साइड इफेक्ट ज़्यादा होते हैं. एंड देन इन पेशेंट्स को वैक्सीनेशन रिकमेंड की जाती है. ये पहले भी रिकमेंडेड थी. अब जो नई गाइडलाइंस है उसमें RSV की गाइडलाइंस थी, RSV की वैक्सीन की ऐड कर दी गई है. बाकी इनको इन्फ्लुएंजा की रखी है, इन्फ्लुएंजा की लग रही होती है, उनको न्यूमोकोविड निमोनिया की लग रही होती है. तमाम वैक्सीनेशन इन पेशेंट्स में रिकमेंडेड होती है. एंड देन पेशेंट को हम कहते हैं कि वो स्मोक ना करे क्योंकि अक्सर पेशेंट में जो COPD होता है वो प्रेजेंट करते हैं स्मोकिंग के साथ. उनको हमारे पल्मोनरी हैबिटेशन का पूरा सेटअप मौजूद है. वहाँ पे डिफाइबर्स हमारे होते हैं जो उनकी रूटीन में एक्सरसाइज कर रहे होते हैं, उनकी अपॉइंटमेंट्स होती हैं. देन ऑक्सीजन थेरेपी भी पेशेंट को दे रहे होते हैं. यहाँ एक बात बतानी जरूरी है कि ऑक्सीजन बेसिकली ना इसका कर्व होता है. अगर पेशेंट को 90 से कम ऑक्सीजन होती है तो वो अचानक से जो है ना या फौरी तौर पर वो 40 और 50 की सिचुएशन पे आ जाता है और पेशेंट कोलैप्स करता है. ज़्यादा एस्थमा हो या COPD हो, अगर पेशेंट को 93 से कम आ रही है सिचुएशन, इवन COPD में तो 95 से भी कम आ रही थी तो उनको ऑक्सीजन थेरेपी दी जा रही होती है. और ये ज़रूरी है कि चाहे एस्थमा का पेशेंट हो या COPD का पेशेंट हो उसको हम जरूर एक एक्शन प्लान देते हैं ताकि और ख़ासतौर पे ये COPD वाले पेशेंट्स को बिकॉज वी नो कि ये एक परसिस्टेंट डिजीज है और ये जो है ना एक्सरसाइज करती रहती है. तो इसका एक एक्शन प्लान होता है किसी के पास कि अगर ये हो तो ये करना है. तो दिस इज MMRC स्केल. ये दिस इज मॉडिफाइड मेडिकल रिसर्च काउंटर स्केल. ये डेस्निया से ही होता है कि पेशेंट की जो है ना कितना ज़्यादा अपना कुछ ब्रेथ हो रही है. सिंपल है ये स्केल. अगर पेशेंट को ब्रेथलेस है एक्सरसाइज करने में तो उसे 0 देंगे. और अगर उसे शॉर्टर ब्रेथ हो रहा है जब वो सब वॉक वगैरह कर रहा है तो 1 देंगे. अगर इवन स्लो वॉक भी कर रहा है तब भी उसको ब्रेथलेस हो रहा है तो 2 देंगे. और उसे रुकना पड़ रहा है अपनी वॉक को, अगर उससे थोड़ी देर के लिए चलता है उसको रुकना पड़ रहा है, बहुत ज़्यादा वो जो है ना उसको ब्रेथलेस हो रहा है तो 3 देंगे. और इवन अब वो लेटे हुए भी उसको जो है ना ब्रेथलेस हो रहा है तो हम 4 देंगे. एंड दिस इज स्टैटिक 4. ये सिंपल 8 सवाल होते हैं. पेशेंट को उसको वेट करना होता है 0 से लेकर 5 तक. तो इससे हमें पता चल जाता है कि उसका जो है ना कर सकते हैं. दैट्स ऑल फॉर टुडेज. अगर आपको कोई क्वेश्चन है यू कैन आस्क.
Thank you so much.